everything should be good. And you can move back and forth between the slide.
And they don't have to, and once they signed on to this, they can just keep their phones and.
Yeah, it's just the very first one. It's the same link for all the ones, even for the second lecture, it's all the same.
Okay.
Thank you very much. So let me know when you're ready. I'll give you, even though they know you'll give your short introduction.
Okay, you can.
Recording's already
Okay, okay.
Okay, and what are we doing in terms of time? There's no clock in here.
What are you looking for?
Time.
Oh, it's
yeah, 10:04. That's okay. Yeah, but I mean, there's no clock. It's hard to tell. Okay.
There might be one behind. No, there isn't. I guess they don't want you to know what time it is.
Okay. Oh, up there. Okay. Thank you.
Okay.
Okay.
We can be guys. We can like gauge.
Okay. Okay, everybody.
All right. Well, thank you everyone for coming. This is our part of our new interactive learning series. And so Dr. Melish, I know that you know Dr. Melish, and she's going to do a highly interactive session based on the material that she posted on your class drive. And so I know that you know her, but I'm going to introduce her anyways. Dr. Melish is a pediatrician with a specialty in infectious disease. She's a professor of pediatrics and also microbiology and tropical medicine here at Jobson. And she's my colleague at Kapiolani. We interact a lot on pediatric patients' cases. And she's also a world expert on Kawasaki disease and also staphylococcal infection. So we're looking forward to this interactive session. So please feel free to, you got your poll everywhere that's going to be part of it, but feel free to speak up, ask questions, and we'll have this as interactive as we can.
And then hopefully, we're going to start out using a lot of poll everywhere, but hopefully we'll start just having you talk, okay? Because that's what interaction is really supposed to be. And there's no reason to, I'm not going to remember you if you say something that you later think you shouldn't have said, so just talk, okay? We're really trying to get engagement. So the first patient I would like you to think about is a 15-month-old child whose mother brings him in. You look back in the record and it's true what the mother says. He seems to be sick quite often. He has 4 episodes of otitis media with fever each time. He visited ER for those. He had 6 visits for respiratory infections, 4 ED visits for fever without any focus, but he has never been hospitalized. He is well immunized. And she thinks this is very odd behavior because she has an older child who had some infections, but never was sick as often as this one. When you look at him, his vital signs look like they're completely normal. His height and weight is at the 75th percentile. He's a happy, interactive child who looks like has no problems in the world. But the mother is quite concerned, thinks this is really very different. She doesn't know any other children that have had this many infections. So what are you suspecting is wrong with this child? So now you can respond, and I'll see if I can do the right things, which is highly doubtful. Whoops. Let's back up.
I might have to just escape to the bottom here.
Okay.
Here we go. We should be able to see that. And I can come up everything.
Okay, well, it's always interesting to see what people are thinking about. But let's toggle back to the next slide. Yeah. So in fact, this is a normal child. The infants and preschool children are immunologically naive, and they can be exposed to multiple common agents, which evade their innate defenses, and they've never experienced these. They're inexperienced. When they're born, their T cells, for example, are 99, 97% naive T cells, very few T cells that are memory cells. By the end of the first year, it may be down to 80% naive and 20% memory cells. That means that they are developing a library of responses, some more than others, depending on how many other children do they see? How many other people do they see? Are they cocooned with their mother for the whole first year of life, which is done in many cultures, or are they out in the world getting sick? Sometimes they're not getting sick, but sometimes they are. But they are developing immunity, whether they're getting sick or they're not getting sick. So that's a natural process. You can do an immunologic workup on such a patient. Very often we do. It's reassuring. And we'll talk about, how to do that next. But you could also just reassure and say things are better. We also find that if you did that, you would see he's got normal T and B cell numbers. You can actually even look at what's his percent of naive cells and a percent of, but highly likely that this child's T cells have matured through the thymus and that he is ready to take on the world. So you also have got the fact that he has an older brother. The older brother goes to school. The older brother is getting exposed to a lot of things. Some of them with asymptomatic infections is likely to be bringing them home as well. This is just naturally how you get immune. So now we have another boy. He's 5 years old. He's had multiple skin infections, usually with Staph aureus. He has a history of liver abscess, and he's had bacteremic staphylococcal pneumonia. He comes in with fever, limp, blood culture, and he has Aspergillus osteomyelitis. Your response is, what the hell? I know about osteomyelitis. It's almost always caused by staphylococci, occasionally streptococcus and pneumococcus. What the hell is he doing with Aspergillus? If you want, you can look up Aspergillus and you'll find out that it's a fungal infection. Okay, so now what are you going to do about this child? A little more information. He had non-focal fever for 17 days in a prior admission. He had a FUO, and he had an abscess in his liver. The liver abscess was excised at surgery. Dr. Thompson actually saw that liver abscess. Instead of being like you put a knife in it and liquid pus runs out, this was pretty much solid, packed with neutrophils. The neutrophils were filled with a large number of Staph aureus. That was in a prior admission before this Aspergillus osteomyelitis. Looking at him, he's now in bed. He's got an IV in place. He doesn't look very sick. He's not in respiratory distress. His only complaint is that his left upper leg is sore. And when you examine it, there's point tenderness just above the knee. He's done reasonably well with his growth so far, with his height and weight both between the 50th and 75th percentiles. His current CBC shows he's got an elevated white count with neutrophil predominance. If you look at this with a pathologist, they'll say that looks like normal white cells. Okay. Now, this is the hard part for me. Okay, now you have to, when you're going to do something expensive like an immunologic workup, you probably have to justify it and get prior authorization from from your insurance company. Okay, well, I think that's true. Why is he getting an opportunistic pathogen for a supposedly normal person? You've already looked up Aspergillus and you found out that It's a particular pathogen for people with leukemia and chemotherapy and for people who are immunocompromised. So I hope they're going to give you the authorization to do the study. Okay. So what are you suspecting? Now we have another question. Oh, dear. Let's back up. Well, sorry, I gave it away. So we'll just go on. Okay. So the question about whether what was wrong, did he have a white cell defect? He had white cells that looked okay. But in fact, he did have a white cell defect. The neutrophils have defects in the NAPD oxidase system. They cannot generate an oxidative burst and produce hydrogen peroxide, which if they were able to do that, that would have killed the organisms that are in the, that have been phagocytized. And this is a problem for intracellular killing of catalase positive organisms is a defect. So there's 5 organisms that account for the majority of infections: Staph aureus, Nocardia, Aspergillus, Serratia, and Burkholderia. And most of the cases are X-linked, but there's 4 genes and 2 inheritance patterns. Their treatment usually you put them on suppressive therapy with Bactrim, which is antibacterial against most staph and Nocardia. So you're working on that. And it has been demonstrated that they have fewer infections if they get regular infusions of interferon gamma. But what you really need to do for them is a bone marrow transplant, because they will continue to have problems throughout their lives with these 5 infections over and over. And each infection is very dramatic and serious, like that liver abscess. The thing about the catalase negative organisms is that they are able to generate hydrogen peroxide within the phagocytic vacuoles in the and they die themselves from the hydrogen peroxide that they generate. So streptococci, for example, don't show up on this list of a small number of organisms. So this is a niche, but it shows you something about a problem with the innate immune system in perfectly normal looking white cells, but causes this condition, which results in repeated, very serious infections that are difficult to treat with antibiotics. So now we have a male infant who was well until 4 months of age, but he developed recurrent otitis media with chronic drainage of pus. By age 1, he'd had pneumococcal pneumonia and Haemophilus influenza. But he was immunized. By 15 months, he had sinusitis and a chronic runny nose. Nevertheless, although he has a chronic runny nose and sinusitis, in your office, he's a happy boy. His weight and height is at the 50th percentile. His exam is normal, and his behavior is normal. He's a normal, active child, very playful. So same questions. What are you thinking is wrong with this kid?
Is it okay if we like practice present like
Yes,
so that they can see both
yeah.
screens?
Oh, you do it like that. That's good.
Oh, dang it.
Okay. Okay. Well, that was an excellent response. So why did almost 3/4 of you choose that? It's pretty smart. So one of these smart people ought to tell me why they chose that.
So what was your thought process?
So he was vaccinated with the goal of making immunoglobulins, and he was having troubles with things like pneumococcus, Haemophilus influenza, things that who are also prominent in causing otitis media. So he's pretty impressive history. Why didn't you think he had severe combined? Well, that was probably a smart question, but smart answer, but why not? Well, I would have said he's that old and he's not dead yet. And that is basically the answer, why he did not have severe combined immunodeficiency. As bad as this seems, he's still alive and he looks okay. And his chances of being alive at that age without a bone marrow transplant already are almost zero. That's the classic bubble boy but we don't do that anymore. We actually try to find them real early and transplant them. Okay, so congenital neutropenia, maybe not a bad choice. Okay, let's go back to the real deal.
I think what we might have to do from
this side. How do I get back?
Just click here.
Okay.
And then maybe go to the
next slide. Okay.
Sorry.
Okay, so now we have a well child. Oh, this is the well child, and this is what you find on his immunologic workup. So you can see the immunoglobulins. They're all undetectable. So those people were right. The lymphocyte subset panel here shows that he's got no B cells. So once again, that supports your diagnosis. But look down here, he does have an adequate number of T cells, natural killer. His natural killer cells are a little low, but he has actually adequate numbers of all of the other components. So that's another reason why he doesn't have severe combined immunodeficiency. And complement is normal, and he shows no response whatsoever to his immunizations. Now, when you look at this panel drives people crazy. That's because it's very complicated, and it gives you both the percent of B cells and the absolute number. But if you look through it, there are the normal values, and you can learn how to deal with this when you are involved in evaluating somebody who has too many infections. And so that's a very important tool, and it also lets you focus and demonstrate where to go next. Okay, so I go here. I'm sorry, I'm doing the wrong thing again. Diagnosis. Okay, so I go, what do I do?
You can click this right arrow.
Okay, I might be able to figure that out. Okay, and now what?
Okay, and then we can put responses to see.
I see. Okay, well, the group consensus was that lymphoma and asplenia are highly likely. But I do see some votes for agammaglobulinemia. For someone who has asplenia, they will have trouble with certain organisms, including the organisms that were a problem for him, like the pneumococcus particularly. And also meningococcus, and we sometimes give them prophylaxis with penicillin or other agents to prevent them from getting overwhelmed by those infections. But those people make IgG, and they very likely make IgM, and they may or may not make IgA. Lymphoma, but anyway, the answer is he has agammaglobulinemia, and this is actually historically a famous type of disease. It was kind of the dawn of immunology. Bruton type agammaglobulinemia. The IgG, M, and A are below the level of detection. The B cell number is markedly low. It's not even detectable. There's no detectable response to protein or polysaccharide antigens. But the pathogens are primarily encapsulated organisms that need opsonization for phagocytosis. Oddly also, enteroviral infections are severe and are not cleared. If you give these people replacement immunoglobulin, they have a near normal life and will certainly can grow into adulthood. So you can replace their immune globulins with someone else's. And in fact, what we do is replace their immune globulins with a preparation that comes from about 5,000 to 10,000 blood donors from all areas of the mostly of the United States, who the plasma is then fractionated, purified down to one single protein, which is IgG, and therefore it is giving passive immunity to someone who had no ability to make immunoglobulins at all. Now, passive immunity is pretty good, but it isn't great. It hasn't got the ability to ramp up in this case of an attack by a particular bacteria. And you may encounter things that this panel of 10,000 people didn't get. But it's pretty broad spectrum passive immunity because they come from all areas of the country, and they're adults and they've lived in the world long enough to have an incredible variety of actual antibodies to specific organisms. It's caused by a mutation in the BTK gene, and it's involved in all stages of the B cell differentiation. It is rare, and incidence is about 1 to 100,000. I think there's about 3 people that I know of who started as children with Bruton agammaglobulinemia. This is a classic success story in a way, and it's a classic, case of what happens. Okay, so next, move on. Now we have a 7-month-old. He's the first child to healthy parents. He did well until age 3 months, and then he fell to the first percentile and less at ages 5 and 7 months. He had developed a cough for 2 whole months, and he was then admitted to the hospital with severe tachypnea. He had low O2 saturations. His chest X-ray showed bilateral multifocal infiltrates. He was admitted to the ICU because he was in respiratory failure and needed respiratory support with high-level respiratory care. He had a multiplex PCR that was negative for viruses and mycoplasma. It was a surprise to the intensivist, but he grew pneumocystis from his tracheal aspirate on the day by PCR. Okay, so keep that case in mind. And we're going to move to the next slide, which just tells you how can you justify doing an immunologic workup on this kiddo. Okay, and now I go to this, and we'll see what you think. Okay, so pneumocystis because why? This is pretty, well, let's see, we can see what else. Okay, AIDS defining. He might, you say, oh, I think this kid has pneumocystis. Maybe he could have AIDS. Good thinking. He's failing to thrive. Okay, so you are all well enough educated to know that pneumocystis is one of the AIDS-defining infections that makes you think about doing an immunologic workup. And he certainly could have HIV. I have seen this exact story with a child that had HIV. So that was good thinking. He is certainly immunocompromised. And let's see what is perhaps the next one. Back to this. Okay, so we're going to get another thing to look at. Let's try to. Can you tell me how to enlarge that a little bit? I think you should bring your computer up here. Okay. Okay, so here's his immunologic workup. What stands out to you here on this immunologic workup?
Are any of the values particularly striking?
He has normal IgM, but he doesn't have any IgG or IgA. And what do you see on his lymph subset panel? Okay, the CDC, the CD19 cells are the B cells. What about his B cells? They're okay, yeah. That's the surprising thing about this one, is that's okay. Okay. So where are we? So here's some more information. His B cell subsets, another thing to look at, are that he has enough B cells, but the B cells are capable only of making the primitive IgM. They're not capable of making IgG and IgA. That is, they cannot class switch from the IgG positive to the, from the IgM positive. Those are the non-class switch, but the class switch, he has no class switched cells, which means he cannot make IgG. He also has a very diminished amount of plasmablasts that would allow him to make IgG specific antibodies. So that's his story. We also looked at his CD4 cells. They had normal activation to nonspecific mitogens and antigens. And we looked for the CD40 ligand, which is what is involved in class switching, and it was absent. We got all those things done that were consistent with diagnosis of X-linked hyper-IgM syndrome. This is far more common than Bruton's type of agamma-globulinemia, another cause of agamma-globulinemia. And we had already figured all these things out last month, because I saw this child last month, before we got the genetic test back, which demonstrated that he has a genetic defect, and it's X-linked. So he has X-linked, quote, hyper-IgM syndrome. This was originally caused dysgammaglobulinemia type 2, and then hyper-IgM immunodeficiency. And it's caused by a deficiency in the CD40 ligand that's required to unite with the CD40 on the B cells, and that prevents the switch from IgM to IgG and IgA. So these patients, though, they have far more than just an antibody deficiency. They may also have problems with their T cells. They may also behave more like severe combined immunodeficiency. And this is the failure of isotope switching in the hyper-IgM syndrome. And also there is a T cell defect, and these patients generally have neutropenia as well. So they are more difficult. As I said, this is more common, and case 5 is illustrative of that. This is a 15-month-old refugee child who had actually been a refugee from Vietnam and had been in camps in the Philippines and so on. He had been hospitalized for multiple bacteremic pneumococcal pneumonias and had been living in very difficult circumstances, but had survived until the age of 13 months when we found he had no IgG. We did start him on, I'm going to skip ahead. We started him on IVIG replacement, but he had no more episodes of pneumonia, but he developed severe diarrhea with cryptosporidium. He had persistent neutropenia. He failed to gain weight. We were never able to clear cryptosporidium from him. He had severe disease due to sclerosing cholangitis, and ultimately developed chronic liver disease and actually died of it. His mother had 2 more boys and 1 girl. The boys followed the same pattern as their older brother and died in adolescence despite all known supportive care while they were waiting for bone marrow transplants. But the girl has been healthy. So what does this suggest to you? It suggests another X-linked disorder. And so these children actually died before we were able to evaluate them. But so this is a more common condition. It is amenable to therapy, but the boy that is still living, the young boy that I just described, when he's about 2, if we can find it, he can have a bone marrow transplant. Otherwise, if he can avoid cryptosporidium, he probably will live to adulthood and even with supportive care, even if he never gets a bone marrow transplant. It's a little bit concerning because his father is from a small Pacific island, and his mother is Caucasian, and a match may be a very difficult problem for him. So in any case, I think that important thing is to avoid getting cryptosporidium, which can be in tap water and can be in fresh water. So avoiding it altogether is difficult, but that seems to be the biggest problem for these patients if they get protection against pneumocystis by prophylaxis. So I think we may have, let's see where we get to next. I was going to ask about the inheritance pattern, but we'll get to another case. Okay, so now we have someone who's sick all the time. She was living in American Samoa, and her parents said that she was sick so often and had respiratory infections and chronic cough and was not thriving. So they, in desperation, moved to Hawaii so that she could get more advanced medical care. And she was age 8 at the time. And that was actually their motivation. They were happy and comfortable in Samoa, but they just said, we're going to lose this girl if we don't move. So her initial chest x-ray showed right middle lobe shrinkage and consolidation. You see this x-ray? See this odd thing coming off of the right heart border? It's very well defined and odd looking. And the x-ray was read as consolidation and shrinkage of the right middle lobe with bilateral lower lobe bronchiectasis. The CT scan showed that strange structure that was on the right heart border. You can now see, actually, it looks like it's calcified. It's so it stands out so well when when contrast is given. There's some large holes within it, but it's clearly not well functioning lung. And you can see also some lower lobe bronchiectasis. And here is this this replaced right middle lobe, which is probably the result of multiple infections. Okay, so now we're going to shift a couple of times to did I go too far?
A little bit more to the right. One more.
Oh, okay.
One more.
Oh, doing much too. Okay. Okay. So. So you're going to actually have kind of a hard time with this one. So she's got an odd x-ray, so treat it, for God's sake. You're doctors, for heaven's sakes. So I think the question is she sick too often? And that's the problem. So you remember when you suspect immunologic problems, when people are sick too often, they have weird infections. The infections do not behave in the way that you would think they should, like it didn't with the staphylococcal liver abscess, for example. The infections they have are too weird. So anyway, you probably have to talk hard to get this done, but we'll go for it anyway. And now we'll go back. Oh, no, I'm doing that the wrong way again. Okay. So here's her workup. Okay. Okay, so immunoglobulins. Okay, it says so. They're too low. Okay. Her IgM is also low. Her IgA is not present. She doesn't have HIV. Her lymphocytes are functioning. Okay. What are you seeing in her T cell subsets? You got B cells. They're even high. Okay. So she also has a class switch problem, but bigger problem she has with her B cell subsets, which I don't think I showed, are that she has a problem generating plasmablasts. Oh, we're way wrong here. That's wrong. Excuse me for skipping ahead. Well, her B cell subsets are here, which shows that she has a very low percent of plasmablasts. So this is, we have talked about that panel, we used it before. So this is a problem that what has happened with her is she's now grown to be a young woman. She's been getting gamma globulin monthly. She maintains trough levels of 600 to 900. She had that right middle lobe removed at age 10. It was virtually no active lung really remained within this dysfunctional area. She has a chronic cough due to her bronchiectasis, but she rarely has pneumonia or otitis. She has developed severe splenomegaly and hepatic fibrosis, which is a problem with what she has. And ironically, she has developed autoantibodies to red cells, Coombs positive hemolytic anemia, which can be controlled by low-dose prednisone. This is also common. So her diagnosis is severe combined immunodeficiency. No, excuse me, I'm wrong. Her diagnosis is common variable immunodeficiency. CVID, it's called. It's the most common, it's probably the most common other than HIV immunodeficiency. It's really quite common, usually presents with pulmonary problems in young childhood. Their life can be reasonably good with immunoglobulin replacement, but they do have some strangely autoimmune phenomenon with autoimmune thrombocytopenia and autoimmune hemolytic anemia, which this girl developed. The genes are usually there's no known genetic defect, and you don't find anything with genetic studies. So the problem here is probably primarily with failure to generate plasmablasts and actually create the further down in the chain and create the antibodies because there's B cells that are trying hard. Okay, so we talked about antibody deficiencies here very, very in detail. These are other transient hypoimmunoglobulinemia of infancy, agammaglobulinemia with other inheritance patterns and other gene abnormalities, hyper-IgM with other inheritance patterns not related to the same gene, IgG subset abnormalities and specific antibody deficiencies. These are very rarely important, but they're often discussed. And IgG subsets are often ordered to look and see if there's an immune problem with them, but usually that's of little consequence. Okay, so now we have a 9-month-old girl from Guam. She has had diarrhea, otitis, failure to thrive, persistent salmonella bacteremia. So she had a weird infection there. She kept getting salmonella despite getting antibiotics. She got pneumocystis, and she had varicella that lasted for a month or so. This was someone that I saw very early in my career here. She was a tiny, listless, thin infant with white patches on her oral mucosa when I saw her at 9 months old. She had no tonsil tissue and diffuse scaly rash. And now we're going to toggle back and go over and okay. Okay. So the high proportion thought she had both a T cell deficiency and an antibody deficiency. And so she did have genetic testing. She had a JAK3 deficiency, and her B cells were blocked at the pro-B cell stage. So this is severe combined immunodeficiency. Most common cause is the X-linked defects in the common gamma chain of the IL-2 receptor, which leads to the blockage of many cytokine functions. These are various gene defects for severe combined immunodeficiency. This patient did, it was early, but this patient did get a pioneering bone marrow transplant. She did well for as long as I know. So that is the severe combined. Nowadays, we try to detect severe combined immunodeficiency within 2 months. It's part of the newborn screen. So all children who are born in hospitals have a newborn screen done. We get notified if they have evidence of thymic dysfunction by decreased production of T cell excision cycles, which is an indication that of active thymic maturation of T cells. So if they have a low number of those, we actually identify for every one person with severe combined immunodeficiency, we detect about 5 others who have just a profound lymphopenia, T cell lymphopenia. Those patients, we're learning about them. They don't do so badly. They have some T cell function, and they also often pick up DiGeorge syndrome, which we're learning actually is more common than we thought, because some of these patients don't have many of the other features of DiGeorge syndrome. They just have the thymic involvement. So that's how things have gone by. And even though this is a very rare disease, it's considered that we do have a plan to deal with these patients. So even though it's rare, we have something that can bring them close to cure by getting bone marrow transplant. And we're finding that if you transplant these children early, by 2 months, the goal is to get them transplanted by 2 to 3 months of age, while they still are protected by maternal antibody, and while they can be, basically kept in the hospital in isolation, they do very well with transplant, even with all these different defects. Okay. So what are we doing? 10. So we're getting close to out of time for this, but we can go on a little longer with these, and then we'll switch to congenital infections. Okay. Oh. Yeah. Mm-hmm. Okay.
You can press this non-negative sign, the minus sign here.
And do what?
Really zoomed in too much, so.
Okay. Sorry. Okay, so here's a child with a fever and stiff neck. She develops a petechial and purpuric rash. She had CSF showed that she had a white count of 740, 92% lymphocytes. An unusual strain of Neisseria meningitidis was isolated. The mother said, wow, she has a maternal cousin who had bacterial meningitis for the 2nd time in Chicago with the same organism, but they weren't spreading it. She's never met her other cousin. Okay, so it's probably too simple for you people at this point, but what do you suspect is going on in this child? Or maybe not too simple. Okay, I know, excuse me, response. Sorry. Wow, you're getting smarter and smarter. Okay, so she has a complement deficiency in the terminal or membrane attack complex components of complement. And these people are at risk for meningococcal infection, but they generally are normal in other respects. This is an example of where complement is very important in nonspecific opsonization of organisms. And so this is a special sort of interesting, somewhat unusual situation. But there aren't a lot of complement-related difficulties within the whole, generation of immunodeficiencies, although I have seen one other person with a different type of complement deficiency that had particularly severe episodes of bacterial infections. So I think that wasn't really very well defined what she had. So there's probably an area of more work. But although complement's an important part, it's very useful for naive people to opsonize organisms that are non-specifically, that are not, they don't have any antibody to. So complement is really very important. It's kind of surprising that there aren't more numerically recognized complement deficiencies. So what did we? So go to case 8, a 6-month-old girl with bilateral interstitial pneumonia, hypoxia. She got pneumocystis. And we toggle over to here. Okay, this is here just to show you that it's very, very dangerous to use large doses of steroid for a period of time. This child had nothing else wrong with them except for the steroid treatment. And you might see this after treatment, people who are treated with frequent asthma or severe eczema, who are lots and lots of courses of steroids, they might end up with pneumocystis. Okay, so I think at that point we've actually done some pretty sophisticated things today. We've talked about how to look at T cell subsets, how to look at B cell subsets, how to see how they interact and inform us about the normal functioning of the immune system. Sorry for the clunkiness of all of this, but I think that we can take a break or not. What do you want to do?
You guys want to take a short break, or do you want to keep going for a short break? Okay, how about like 5 minutes?
Okay. Okay, thanks a lot. Yes.
For the common variable immunodeficiency, you said that they have like a predisposition to the autoantibodies.
Yes.
Do we know where those come from if they're not able to make?
Well, yeah, it's. I don't honestly know the answer to that question, but it is known they also have a tendency to develop another odd disease, which is of their liver, which unfortunately predisposes them to things like splenomegaly so it's just a known thing. They've got they probably can make they have B cells, they make autoantibodies somehow or other, and and you can treat them by suppressing their autoantibodies. They usually go on to develop thrombocytopenia at some point. They develop a peculiar type of stiff liver with non-cirrhosis, nodular hyperplasia. It's called non-sclerosing nodular hyperplasia, and that their splenomegaly is so large it contributes to their thrombocytopenia, but they also autoimmune thrombocytopenia. So it's an odd condition.
We don't really know. There's all these things that are happening.
Well, I don't really know. Okay, I just know that that's a well-known phenomenon, and I've 2 patients who have that.
Thank you. I think it's working out, having the two screens and going back and forth like that.
Embedding would work better.
Yeah, embedding would work better.
So I'll learn how to do that.
We'll
Yeah.
work on that
Yeah.
the next time.
But sorry, I didn't have the time
Yeah.
to learn to do it.
And I will learn how to do it, but I
Yeah.
don't know how to do it at this
Yeah.
time. But I think those are all really, really good cases, and I remember some of them.
Uh-huh.
Because I know it's involved in some of them.
Yeah.
I can pull up the next.
Yeah.
Next
Good.
sheet.
Thank you.
No
We'll probably
problem.
need to do that.
Okay. As of right now, I feel like what we were doing last time was like probably the most efficient way that I can think of going back and forth.
You mean the last hour?
Yeah.
Yeah, no, I think so. I was saying that to Dr. Melish too. I think that's working out.
Okay.
If only I was a little better with the computer.
No worries.
That's okay. And again, this is the first time.
Yeah.
So we're kind of learn what works best, and the next time we can
Yeah.
have some.
Right. I think the main thing is we just have to go through the slides based on what's on the sidebar.
That was good.
And then we can adjust zooming in or out here.
Uh-huh. I see. Okay.
Good.
I never even knew what that was for.
And same thing, I can just activate the questions from the laptop. So.
Okay. And then what about, is this ready for the next?
Yep. So everyone, it's the same link. So once, I think once we get to that question, I'll activate it so that people can start answering it.
Yeah.
Yeah.
Okay.
And then we just have to go to responses to see that response.
Okay. Oh, and I want to get to my last little piece. So. Where's the computer here?
Oh,
maybe he comes back. Okay. So what do you really think? Oh, sorry. Okay, so you got a call from the delivery room. It says, come and see this newborn with a rash. So here's what you're seeing. I hope you can appreciate that this newborn has a lot of spots and that they are red to purple. He has some peeling of his hands. Remember, he's just been born. You can see that his hair is still sort of sticky and matted down. He hasn't even been washed yet. He's just a brand newborn baby. When you're feeling these run your finger over the course of some of these, you can see some of these are actually nodules. So some are flatter, but some are actually nodules. And there's one particularly above the eye near the bridge of the nose that is really an obvious round nodule. They're over his entire body. Once he's weighed and measured, you can see he's a little bit small. Okay. So let me see. Let me go up to this one.
Is there which question are you trying to?
Yeah.
The first one or the?
Wow.
Can you click one more time, please? This one, or what do you want to go?
Oh, that was maybe the one that was supposed to be. Yeah,
Okay, you can go back.
Go back. I'm sorry. Okay.
And then if you want to go.
Okay. There you go. Okay, well, you answered the first and the second question here. This definitely could be a congenital infection, and it could be CMV, which you've answered the most often. So, in fact, CMV is the most common congenital infection. Of the agents here, CMV, toxoplasmosis, and rubella, HSV. Is there anything about how the baby looks that would differentiate? His head is small. And why would that, how would that help you differentiate one from the other? So would you see that a small head in rubella as well? Would you see a small head in? Well, probably he might be jaundiced with any of those conditions, but this baby was in the delivery room, so he may not be jaundiced at all because his maternal system would probably prevent him from being jaundiced at birth. So I think somebody probably knows, that was a smart question that asked about the head was small. So we'll just leave that for a moment and talk about that a little bit later. But I think you might think that if it had been larger, you might think about toxoplasmosis more than some others. But the truth is, you can't distinguish these one from another on what you've seen in that particular baby so far. So I had a couple other sort of sillier things there. I thought we could just flash them by. Most common congenital infection, we've already said, the most common is cytomegalovirus, I mean, is CMV, cytomegalovirus infection. And if it wasn't a congenital infection, what might it be? Well, every time you make a diagnosis, you have to think about what else would be in the differential of somebody who's got purple spots. So these are things that are, it could be parvovirus, could be thrombocytopenia, so they're coming through. It could be, he could be thrombocytopenic. He could be very anemic and making erythropoiesis in his skin. That's the so-called blueberry muffin lesion, and he was probably showing that with that lesion over the forehead. So he could be profoundly anemic. He could have parvovirus, which I saw down there. So there's a lot of other things that could, but this was born, you know, no rupture of membranes except just before delivery. So this was a kid who was clearly born with what he has. So this is a congenital infection, or it's one of these other things. I think a congenital leukemia is also something else to think about, and some histiocytosis can present early. So there's a broader differential, but congenital infection is going to be first in mind for many people here. So you're thinking along that line. Okay, so I think we're go back to this. So looking at these things again. So he's small for gestational age, less than the 3rd percentile, height, weight, and head circumference. He had large blistering lesions on the hands and feet and discrete raised, non-blanching red-purple spots throughout the body. His vital signs are normal and he's breathing easily. On exam, he has an enlarged liver and spleen. We don't have any lab tests yet. Okay. APGARs were 8 and 9 at mother's history, maternal serology, okay. So back over here. Okay. Mother's 25, no prenatal care, precipitous delivery, no lab tests are available. So what do you want to do next? Okay, well, a lot of people are really want to do PCR for CMV. Oh, okay. Okay, well, thanks. So we did do an RPR on the mother. It was 1 to 64, but the infants was 1 to 512. So the infant CBC is here.
Bigger?
Bigger, yeah. Yeah. So the infant CBC is here. And he had low platelets. His hemoglobin and hematocrit were low for a newborn. And on the second and third day of life, he already had elevated total bilirubin, and surprisingly, a large amount was direct. It would not be at all surprising that if it had profound elevation in indirect bilirubin, but the direct bilirubin is a concern. So now that you know he is syphilis exposed, there is this incredibly complicated algorithm that we follow to decide whether this patient is highly likely to have syphilis or less likely, or we've ruled it out. So with maternal antibody being positive, no history of treatment in pregnancy, this child is definitely goes down this algorithm until he gets to the final stage where the child is abnormal and he has a titer that is greater than his mother's antibody titer, indicating that he has been in utero reacting to the syphilis organism. So this child could have congenital syphilis, which is probably the second most common congenital infection that we're likely to see. And this has become very much more common. This algorithm is here just so that you can see how complicated it is to actually make a diagnosis in a lot of situations where we have a requirement to prove that the patient has, if they've had any therapy, they've had adequate therapy, and how the child is doing. With the situation of proven or highly probable congenital syphilis, we will check for bones, and we'll treat them with antibiotics for 10 days. We'll check their CSF to see if they have evidence of CNS involvement. We'll check for the long bones. We have the ophthalmologist check to see if they have any eye abnormalities. In this case, the patient the patient did have CNS involvement, extensive long bone abnormalities. His elevated direct bilirubin persisted and worsened. He failed to thrive in the first 5 months of life. He had actually developed liver failure and had a transplant at 5 months. By 5 months, he was actually his RPR was now negative. He'd actually been adequately treated for this, but he had the complication of having a liver transplant. So congenital syphilis is on an incredible rise in the United States. From 2012 to present time, there's 750% elevation in number of cases of exposed or children who were born with congenital syphilis. We almost always are treating 1 to 2 cases at a time for proven or probable congenital syphilis. We have not gotten a handle on this, although there's been slightly decrease in new cases over the last 2 years. So this is a really serious problem. CMV is still the most common of the congenital infections, but syphilis, unfortunately, which had been cut way back, is now a very serious problem. Okay. So now we have a new patient. See if we can move this a little bigger. I have trouble getting that to get bigger. Okay. So she came in at age 4 weeks, but she started to change at about age 2 weeks, where she started to have very few stools, only once every 3 days, which is very unusual in a newborn. She was feeding well, but then she became, the abdomen became very distended, and the child became less active. She was seen at her 4-week appointment by her physician, and was noticed that her head circumference had increased dramatically from the 10th percentile to the 98th percentile. The abdomen was distended and soft, non-tender, and she was sent to Kapiolani for evaluation. Past medical history was she was born at 40 weeks gestation, the first baby to this mother. Prenatal care was in the first trimester. Syphilis testing was negative, rubella immune, GBS positive. Penicillin G was given in labor. The infant was well at birth, and the head circumference was in the 10th percentile. The length was in the 25th, and the weight was in the 10th percentile. Got an uneventful newborn stay, did well until she came in. Had a surgical consult that said her abdomen was distended but normal. Hirschsprung's disease was actually ruled out. She had spinal fluid, which showed white count was 24, which is elevated. Glucose was close to normal, slightly low. The protein was markedly elevated, and the gram stain was negative for bacteria. And further developments, maybe. But, oh, sorry. I went. Okay, so we want you to do some orders now. Okay. She had imaging. Both ultrasound and MRI. You want CBC and various other things. This is her CT head. So the radiologist read that severe ventriculomegaly with evidence of severe pressure against the brain, with scattered calcifications prominently in the periventricular region. These cranial sutures were splayed, which you can see in the skull here and here. They said findings are most consistent with sequelae of intrauterine infection, such as cytomegalovirus was the reading. So CSF PCR for toxoplasmosis was positive. The IgG, IgM, and IgA were also positive. CSF shunt was placed. She was treated with Bactrim initially because pyrimethamine was not available at that time, but then she was switched to sulfadiazine, pyrimethamine, and folinic acid for planning to be done for 1 year. And the ophthalmology showed that in the right retina, there was a large leucoma in the macula. So at 8 weeks, she was at home. She was markedly improved. Her mother said she was much more active. She was passing stools 2 to 3 times per day. She was smiling and developing a personality. She was no longer distended. So she had actually a very rapid and clinical improvement when she started on antitoxoplasma therapy. At 8 months, she came back for evaluation by neurosurgeon, and she had a BP catheter placed at the first hospitalization. And you can see now that her ventricles are still large, but much smaller, and that she has normal extraaxial spaces, so she's actually doesn't have a brain under pressure, absolutely pushed up against her skull, which she had before. You can see there's sulcation in the brain, and she also has kind of a flat head, probably because her head was so large that she was, when lying on her back, she was unable to move as much as she should have been. But at 8 months, she was alert and happy. She was very interactive with the mother and not afraid of strangers. She smiled and laughed responsibly. If she was placed in a sit, she could sit unsupported, but she couldn't actually get to a sitting position, which she should have been able to do at 8 months if she had been completely normal development. She did still have a head lag, and her head is heavy. She couldn't lift it if she was placed prone. But she also showed the decreased use of her right arm and right hand, and decreased tone in her right arm and both legs. She couldn't bear weight on her legs when she was held upright. And she had a major scar right in the macula on the right, which ophthalmologist opined that she probably would have severe visual impairment on the right eye. So at 17 months, she was fully active and interactive. She actually was able to speak a few words. She could only look at you with her left eye. She does not fix with her right eye, which wanders all over the place while she's sitting there. She can sit alone if she's placed in a position that's comfortable for her. She still doesn't use her right arm and leg more than she had at 8 months, but she's doing a lot with her left arm and hand. She can't crawl, but she can, and she doesn't bear weight yet. A year later, she was actually walking, still had weakness on the the right side and right hand. So this was actually, for such severe neurologic involvement, this was actually a good outcome for toxoplasmosis. And remember, this child was actually looked normal at birth, and a lot of things changed in the time that she was, she progressed rapidly. I think the important thing to think about toxoplasmosis is that the damage will go on. If you don't diagnose it correctly, the damage will go on. It will continue and continue in various ways. So I had a different experience, a child that had a prenatal diagnosis of moderate hydrocephalus, which was compatible with aqueductal stenosis. This child looked normal at birth and was discharged at 2 days old with a referral to go see a neurosurgeon. She was successfully shunted, but she came to attention at 18 months because she had severe neurologic delay. She was semi-aware. She was largely unresponsive. she had very dense lower extremity paralysis. At that time, she was diagnosed with toxoplasmosis. Her IgG was high, her IgM was negative. After therapy for 1 year, she had a modest improvement in alertness. But up to the age of 18 months, not one of many medical personnel ordered testing for the cause of her initial hydrocephalus. So she had been successfully shunted, but she had, further ongoing damage, not due to pressure on the brain, but due to ongoing disease with toxoplasmosis. And we believe that toxoplasmosis is more common in Hawaii than in other areas. We have evidence that toxoplasmosis is a problem for our monk seals who are endangered and also for our endangered forest birds. And we know we have a lot of feral cats. We just did a study on a serum bank of women that delivered at Kapiolani Medical Center from in the 2008 to 2015. And we found that seroprevalence on this small sample that we did so far was about 4 times higher, about 18 to 20, which is 4 times higher than through most of the states in the United States. So toxoplasmosis is here, but it's underdiagnosed. It, like all congenital infections, the spectrum of involvement can be like total damage, like the child that I discussed in a paragraph here, to moderately good outcome in the child that got shunted and treated.